Hi, and welcome back. Today we're going to be discussing health policy from the lens of health insurance. Now, health insurance is an incredibly complex issue and topic, and really is the subject of entire courses of study. Um, so, what I'm going to try to do today is really just lay the groundwork and get you familiar with what some of the terminology is, as well as discuss what some of the trends have been and what's going on currently in health policy. And there's a lot going on right now in health policy. So, to get started, it's important to understand the terminology that we'll be using. So, something that's been in the news and has been in the news for several years now is this idea of universal health insurance. And there is no one definition to universal health insurance, and there's no one way to have universal health insurance enacted. In the United States, we currently do not have universal health insurance. The Affordable Care Act, which we'll discuss more in detail in a little bit, was supposed to be a first move towards universal health insurance. The two main systems for universal health insurance are government supplied health insurance, or government owned health insurance, or government supplied care, and third payer. So if you look at a system such as the Canadian system, doctors are private employees. They do their work much like they do in the United States. However, instead of the employers providing health insurance, the government provides your health insurance. So everyone gets health insurance through your government that is paid for through taxes. You can also purchase additional health insurance in Canada to cover things that the government healthcare does not cover. So it's universal in terms of everybody has access to health insurance, and there is a set amount or a set of services that provides, that insurance will cover. If you want things that are above and beyond that, you can pay either out of pocket or you can purchase private insurance to cover those things. A different system would be the British system. In the British system, the doctors are in the National Health Service are employees of the government. Therefore, when you go to see those doctors, if you go within the National Health Service, there is no insurance to be paid. Again, they are paid a salary that comes from the government, and when you need care, you simply go, you get your care, you leave. There are no bills to work out. So they're slightly different systems. In the UK as well, there's also private insurance that you can purchase that goes above and beyond if you want highly specialized services or if you'd like to see a physician outside of the National Health Service. So those are two different ways of looking at universal health insurance. In the United States, I cannot imagine a scenario in which we would have a system like the British system. I think there would be significant pushback to that. But if you look at things like Medicaid and Medicare and the veterans system, those are all third payer options. Those are similar to the Canadian system. For Medicaid and Medicare, I'm going to touch on them just very briefly because there's going to be a whole separate video about them. But basically what you need to know is Medicare covers low-income individuals and the permanently disabled, while Medicaid, I'm sorry, I got those backwards, see? Medicare covers the elderly, people who are 65 and older, and individuals who are permanently disabled, while Medicaid covers low-income individuals. And that can include people who are permanently disabled, as well as the elderly, if they're both low income, which are considered to be dual eligibles. So we'll talk about that more later. A deductible. So if you have car insurance, you should be familiar with what a deductible is. So a deductible is the amount of money you have to pay before your insurance will kick in. So you go to the doctor, you have a $500 deductible. You have to pay the first $500 of your medical care before your insurance will start paying. Depending on the plan you have, you may or may not have deductibles, and how high your deductible is can vary. So some plans have no deductibles if you use what's called an in-network doctor, a doctor that is contracted with your insurance company, and then you don't have a deductible. However, if you want to see another doctor, If you don't like those doctors and you want to pick somebody else, you may have a deductible. Again, that can be anywhere from $500 to $1,000 or more. Employee-sponsored coverage is how the majority of Americans, working Americans, get their insurance currently. So this means if you are employed, your employer provides your coverage. This is highly variable. Often higher paying jobs provide better insurance. Larger companies tend to be able to provide better coverage as well because they have more negotiating power with the insurance companies to provide better coverage for lower cost. COBRA is a type of insurance. It was a result of the Consolidated Omnibus Budget Reconciliation Act of 1985, which added healthcare continuation requirements that apply to group health plans. So if you have an employee-sponsored coverage, you get your insurance through your employer, you leave that job, you are eligible for COBRA, which means that you can maintain your health insurance. However, you also have to pay the full cost of the insurance. So typically with employee-sponsored coverage, they pay part of the cost of the plan, and the employee pays part of the cost. If you leave your job and you take COBRA, you are solely responsible for the full cost of that plan, which is called the premium. And that can be very expensive, especially if you're no longer working. The premium, that's what your plan costs. Now, if you have employee-sponsored coverage, you typically pay a portion of that. So it can be you pay 25% and your employer pays the remaining 75% to cover the cost of the plan. Again, that varies with job to job. So when you're out on the job market and you're looking at the benefits package, that's one thing that you should be looking at. Right? So what is my employee-sponsored health insurance? What do they cover? What do I have to cover? And so forth. Cost sharing. So no insurance company is going to pay the full cost of your care. So there are two ways of doing that, of having cost sharing. After the deductible, if there is one, there are co-payments and co-insurance. A co-payment is a flat amount that you pay depending on the doctor you see. So this could be $5, $10, $15, $20, $25 or up depending. So for most doctors, if they're in network, you may have a $15 or $20 copay. Hospitals, if you're admitted, it might be $50. The nice thing about copays is that you know exactly what you're going to be paying. Coinsurance is the percentage of the bill that you have to pay. Typically, this is a 20-80 split, meaning you pay 20% of the bill and your insurance provider will pay the other 80%. However, it's important to note that insurance companies pay what they consider to be the standard reasonable amount. So they have a certain amount that they think a doctor's visit should cost. Let's say that's $100. That would mean that you're responsible for $20. They pay $80. However, if your particular doctor thinks that the bill should be $150, the insurance will only pay 80% of what they consider to be the reasonable amount. Meaning they would pay $80 and you would pay $70 of that bill. So it's important to know, again, the type of coverage you have and whether you have co-payments or co-insurance. Preventive care I'm going to cover a little bit more in the next slide, so I'm not going to go over that. And we've talked a bit about private care. So again, where you get your insurance. Primary care providers are the first doctor you see. So depending on the type of healthcare plan you have, you should have your primary care provider and then you have specialists. If you have insured through an HMO, a health management organization, you are required in most cases to see your primary care provider to get a referral before you can see a specialist. If you have a PPO, which is a different type of health insurance, you typically can see a specialist without first getting the referral. So primary care providers in an HMO are gatekeepers. They're supposed to keep down the cost by not letting everybody see the specialists which provide more expensive care. Uninsured is pretty straightforward. There are people who do not have insurance. And we'll talk about what those rates are and how they've changed in a little while. But there's also something called underinsured. So if you think about all the things I've just talked about, the premiums, your deductibles, and your cost sharing, it is quite possible in this country to have insurance and still not be able to afford to go to the doctor. So that can be because the deductibles are high, because it has high cost sharing. It also can be a result of having a job that doesn't provide you with paid sick leave, which is not required in this country. And so it could just be simply too expensive for you to use the healthcare. So having access to health insurance is not the same as having access to healthcare, and that's an important distinction. So levels of prevention. If there's nothing else you learn in this class, I would like you to learn what the levels of prevention are. Because at its core, public health really is about prevention. We have a prevention focus. So when we think about levels of prevention, we think about what the strategies are, what the disease status is, and what the effects are that we would like to see. So first we have primary prevention. Primary prevention targets people who are susceptible to the disease or the outcome but don't currently have it yet. And we want to reduce the disease incidence. We want to reduce the number of new cases. So some examples of primary prevention are vaccines. Right? Infants and newborns are very susceptible to infectious diseases because they do not have immunity that's been built up yet. So it's recommended that they get vaccines to try to prevent the onset of that disease. Some other things that could be primary prevention: not smoking, or smoking prevention programs, physical activity, air quality, and we're thinking about health policy, wearing a seatbelt. Actually, no, I'm going to put that in a different category. So those are all primary prevention strategies. Secondary prevention is when somebody has the condition but is asymptomatic, so they're not yet showing symptoms. And what we want to do is reduce the prevalence or the consequences. So we want to try to treat those people before they start showing symptoms to help them improve and reduce the consequences of a disease. But what's the point? If they're already sick, why should we find it? Well, because we know in many cases, treating somebody earlier reduces the consequences, and it increases the risk that they will recover and reduces the risk of mortality. So we think about things like cancer screening or screenings in general. So blood pressure screening, colonoscopy, right? So the idea is you want to try to find the condition before you start showing symptoms and treat it so that you recover and reduce the long-term consequences. And last is tertiary prevention. So this is when somebody has the symptoms, they already have the disease and they're showing the symptoms, and what you want to do is reduce the complications or disability. You've fallen, you've broken your leg. It's too late to prevent the leg from breaking in the first place. There is no asymptomatic phase for a broken leg. However, we want to reduce the complications and disability, so we do things like physical therapy so that you can recover and reduce the probability that you are going to have difficulty walking once that bone heals. So primary, secondary, tertiary prevention. For this course, you should be able to identify what the levels are, the disease status that's associated with each, what the intended effects or consequences are, and provide an example. And so, just as a reminder, when we're thinking about clinical health, you're thinking about maximizing individual positive outcomes. But public health is looking at minimizing adverse collective outcomes. And so we're looking again at those population levels. So the health services pyramid. The base of the pyramid are, again, those population based public health services. This should be helping, as we said, everybody across the board. This is the safety net. This is the line below which we do not think people should fall in terms of health. Then we have primary health care, those general practitioners and the doctors you typically see for physicals, when you have a cold, when you're not feeling well. Then you have your specialists, and then you have your super specialists. So you will, let's say somebody's having symptoms, right? So you've been a long-term smoker. You're starting to show symptoms, you're coughing, you're not feeling well, your chest tightness. You go to your primary healthcare doctor. They listen to your heart and your lungs. They're concerned. They send you to a cardiologist to see if there's a problem. And as it turns out, you need surgery because your arteries are all blocked, and therefore you need a cardiothoracic surgeon, tertiary care. And so what happens is, as you move up, cost goes up. And so if we're thinking about health and where to intervene and where we should provide funding, the most cost-effective place to provide funding is really at the population-based health services. Again, if we think about the levels of prevention, if we intervene in primary and secondary prevention, it's much less costly. So preventing something from happening in the first place is more difficult, but also more inexpensive than treating it after it's already happened. And so this is a look at what we've been spending. So this is per capita, per person, in national health expenditures. And you can see there's been a dramatic increase from 1960 to 2010. And we're currently somewhere around the $9,000 per person range. And that has been projected to increase. Now, again, these projections were done as of about 2010, 2011, and they've changed somewhat. But you can see we pay a lot for healthcare in this country. So looking at healthcare expenditures as of 2015, we were spending a total of $3.2 trillion. That was up about 5.8% to about $9,990 per capita. So that's per person per year. 16.2% of our gross domestic product is spent on healthcare expenditures, and that's been growing since 1997 after a slight decline in the 1980s. Not quite half are public expenditures. That means directly from the government. And again, that's up a little bit since 1990 and 1970. And so if you look at public expenditures, if our overall spending is $9,990, federal is just under $3,000 of that, about a little over $1,600 are state and local costs. The rest is made up by individuals. In the UK, which we talked about just a moment ago, the total public and private cost is $3,935. So where's the money coming from, or where did it go? So just over half of our nation's healthcare spending goes towards physician and clinical services and hospital care, followed by prescription drugs or other medical care. So non-durable medical products, home health care, residential health care, etc. But you'll note, out of this very large pie, $3.2 trillion, 3% goes to public health activities. So we are not in this country largely investing in public health activities, even though they're the least expensive and even though they can have the largest impact in terms of population health. And who's paying for all of this? Where's this $3.2 trillion coming from? Well, as you can see, the very biggest slice of the pie is health insurance. Now, when people think of health insurance, we like to think that we are all responsible and we pay for it. But what we see is that most of that is covered by Medicare. We pay 33%, but most is government. So that's Medicare, again, the elderly and the permanently disabled. A smaller portion is Medicaid, so low-income individuals. Part of the Medicaid expansion, which is at the state and local level, and then the VA. So the VA, Department of Defense, so Veterans Services, enlisted individuals, and CHIP, which is the Child Health Insurance Program. And then about a third of health insurance in this country is paid through private health insurance. That's either people who purchase their insurance privately on their own or get insurance provided by their employers. Again, where's the money coming from? Investments, third-party payers, and out-of-pocket is about 11%. So this is looking at what the rates were, up to 16.2% as of 2005. And this is where the percent of the national GDP expenditures for health-related purposes were when you were looking from 2010 to 2019. You can see the blue line shows what the final pre-Affordable Care Act projections were, and they were skyrocketing. And then the red line are the actual and most recent projections. So in actuality, while we were projecting the percent of the GDP to continue, and this is from the Congressional Budget Office, this data, the actual numbers have gone down, decreased slightly, and then they begin to increase again with Medicaid expansion that happened in 2013. And while that's expected to continue to go up, the increase or the rate of increase is significantly less than it was pre-Affordable Care Act. So what does all of this spending get us? We're spending quite a bit on health expenditures. Where do we rank in terms of life expectancy? This chart's a little bit old, but it actually hasn't changed that much, so I'm going to leave it. But you can see at the top you have Japan. So we have females on the left, males on the right. And then down here we have the United States. So females tend to live about 5 years less on average. And men, it's about a little over 3.5 years. And we talked about Canada and their third payer. Universal health care, and often when we discuss this and when the argument comes between the people who are pro-universal health care, people who are anti-universal health care, Canada gets brought up into the mix. And it's interesting because two people can look at the same exact data and come up with a different conclusion. Some people will say the Canadian system is terrible and it's failing, and other people say it's a model for what we should be doing. What I will leave you with is that they rank higher than us. So the United States, in terms of life expectancy, ranks behind several other countries. We have life expectancies actually similar to Cuba, which spends significantly less than we do. And we have life expectancies currently less than Chile, Costa Rica, Northern Ireland, etc. And this is another way of looking at life expectancy. So over here, this is your life expectancy, average life expectancy. On the right, this is per capita spending on health insurance. And what you can see is these bars are your life expectancy, and the line is what the country is spending. We stand out. We pay far more for healthcare than any other economically developed country in the world, but we do not have the best health outcomes. So, if we want to get healthcare spending under control, it's very important to figure this out. What can we do differently? What are other countries doing that we can look at? And so if you look at who is right next to us here in Costa Rica, who has slightly higher life expectancy, they are spending just over $1,000 per capita, per person, per year on health insurance. Again, let's see, this is Canada here. So they're spending about half of what we spend with longer life expectancies, similar to Japan. Now, there is a point at which spending less gets you less. So if you look down here at countries like Sierra Leone, Botswana, etc., they have very, very, very low healthcare spending, and they also have very low life expectancy. So you can see that here as well. South Africa, very low life expectancy, very low spending it's as well. So there is a point, and this is called your return on investment or an ROI curve. So there's a point at which spending more does not get you more, right? So it sort of plateaus. If you look here, this is Cuba. They have good life expectancy. They spend very little. Japan, Switzerland, and here's the United States. We spend the most, but our curve actually comes back down. So we need to figure out what the people over here are doing because they're getting a better return on their investment. And this is looking at what the public health spending has been as a percent of the total and per capita. So if we're spending almost $10,000 per person per year, only about $250 of that, not $250,000, not $2,500, that is not multiplied by anything. $250 per person per year goes towards public health spending. In recent history, that has varied somewhere between basically 2 and 3%. So 250 divided by 365, it's about 68 cents a day per person. Okay. Can't even get a cup of coffee for that. That's what we're investing in public health. And that's where some changes need to be made. So some important keys to understanding insurance. Right now, the insurance system is technically mandatory through the Affordable Care Act. You are required to have insurance, whether that's through employment, the government, or the private market. And something that I want you to consider, and this is one of the discussion questions for the online discussion board, is when you're thinking about what insurance is to change today and how it might change, what level of coverage people should have. So what types of benefits should be included and who should be responsible for the costs and what's reasonable. Okay? Right now, eligibility for job-based health insurance is up to employers. Not everyone offers insurance. Even under the ACA, there are waivers. So for small businesses, under 50 employees, they don't have to offer insurance. And those offers only need to be made to full-time employees. So if you're a part-time worker, you're not necessarily guaranteed medical coverage through your employer. And with that, the type of coverage. Again, what is the cost sharing? What is the quality of the insurance? Now, the Affordable Care Act has normalized that to an extent by setting certain rules and certain base regulations for what needs to be covered, but there's still dramatic variation in access to care based on the type of insurance you have. And health coverage is not static. We do not all have health insurance all the time. There are things that can cause that to change. And so back in 2004, there were about 45 million people who were uninsured at any given time. But if you look at the rate of uninsured over a 2-year period, that was 80 million. And that's because approximately 2 million Americans were losing health insurance every month, often for a short period of time. So they'd have insurance, they might change job, they lose their insurance. They'll get it back before the end of the year, but at any given time, 80 million people were uninsured. After the passage of the Affordable Care Act, that number went down to 33 million uninsured in 2014, so about 10% of the population. And almost 90% had insurance for either all or part of 2014. And the number of uninsured decreased again in 2015, down to 29 million. So now we're down to about 9%, and 90% had insurance for all or part of the year. And what can cause your health insurance to change or your coverage to change? Well, if you lose your job, you can lose your insurance. If you change jobs, you can change your insurance. A change in family status, divorce. One of the most likely to be uninsured, or groups to be uninsured, are divorced women who were not in the workforce prior to their divorce. So they get divorced, they no longer are covered under their husband's plan, and they are now suddenly uninsured. Having a birthday. So what used to be prior to the Affordable Care Act, when you turned 19, you were no longer eligible to stay on your parents' insurance unless you were in college full-time, which you had to prove. That has now changed to the age of 26, regardless of whether or not you were enrolled in higher education. So, however, when you turn 26, you're kicked off your parents' plan, one way or the other, and you need to find insurance. And moving. People move out of state to different states. And because we do not have a federal plan, moving can change because different states have different plans and they are not portable across state lines. So the good news is the rate of uninsured has fallen. It is currently at the lowest it has ever been on record. You can see prior to the creation of Medicaid and Medicare, which happened in 1965, the rates were 25% or higher in some cases. Medicaid and Medicare caused that to drop, and they sort of leveled out somewhere between 15 and 20%. With the first open enrollment for the ACA in the marketplace, that has now dropped to less than 10% for the first time ever. And you can see who that has helped. Primarily young adults. So young adults were the most likely to be uninsured, that 19 to 25. You got kicked off your parents, and you didn't yet have a job that was good enough to offer you health insurance. Or you were continuing into graduate studies, which doesn't count. With the ACA expansion of dependent coverage, that dropped. And then with the open enrollment again, that dropped again to the lowest rates that those have ever been. Non-elderly young adults, 26 to 64, there had been an increase that leveled off, and then that has also been declining. And in 1997, the Child's Health Insurance Program, CHIP, was introduced, and that has, you've seen sort of these declines in uninsured rates, which have been helped along by the Medicaid expansion for children who are dual eligible. If you look at non-elderly, it has also caused reductions based on income. So for individuals who are very poor, it's increased it a little bit. For people who are between 138 and 100 and 400% of the poverty line, you've also seen a reduction from about 19 to 12 or 13%. And for these individuals who are greater than 138%, there has also been a decline due to access to affordable health care on the market. But this reduction over here has been due largely to Medicaid expansion. So that said that it expanded healthcare to low-income individuals who are not parents, which Medicaid did not cover previously, and also made the income requirements less stringent, so it allowed more people onto the plan. That being said, as we'll discuss, after the enactment of the ACA, the Supreme Court ruled that states could opt out of the Medicaid expansion. And here is what you see. This is the rate of decline of uninsured. So in states that had Medicaid expansion, that went ahead with that, the rate of decline of uninsurance was much higher. So in Nevada, for example, the decline in uninsured was about just over 8%. And you look in non-Medicaid expansion rate states, the percent decline in uninsured was much less. So those individuals were now required, there's a mandate to have health insurance, but if they can't afford it, they still fall into that coverage gap. So when we say there's still about 22 million people, 25 million who are uninsured, that's where that happens. There's a coverage gap. It still exists. So about 67% of individuals get their health insurance through private health insurance. That's either employer-based, the vast majority, which is about 56% of those people, or direct purchase. So they're purchasing it on their own. Private health insurance accounts for the other third of health insurance types. About 20% is Medicaid, 16% is Medicare, and sorry, that should be a percent, about 5% is military coverage. So that includes current enlistees as well as veterans. So what exactly is health insurance anyway? So it's a product, though it's not necessarily considered a catastrophic, right? So is there a lifetime maximum? There isn't anymore, and we'll talk about that. But basically, it's a prepaid health benefit. You are paying into something with the promise that you will be insured in the future, right? And by having healthcare, you're negotiating both rates and access. So, most often, you are not doing this as an individual. As we just said, most people get their insurance through their employer. The employer negotiates what the rates are going to be and what kind of care you are going to get with the insurance company. Right? That's called care management, managed care. If you get your insurance through the government negotiates that. They negotiate directly with providers for what the rates and what the access will be. Now, obviously, if you've ever negotiated on something, if you have a large group of people that are paying in, you have more leverage to negotiate. Pardon me. If you are going in as an individual, you only have yourself. You're not bringing as much to the table, your rates are likely to be higher. So the reason why you have these group health plans is because you can actually negotiate for better rates and better access. And one of the arguments about having a third payer government option is that the government would cover everybody. And so they would have more negotiating power. Why does it matter? Well, this is looking at a survey that was done asking people about barriers to health care. So, 47% of people who were uninsured in 2003 postponed care because of the cost. But so did 15% of people who had insurance. Again, those uninsured, the underinsured, remember? So they have health insurance, but it costs too much to use it. And why does this matter? Well, we'll talk about that on the next slide, but postponing care, remember thinking about primary, secondary, and tertiary prevention, means that you're not going to show up before you get the disease. You're not going to show up when you're asymptomatic. You may not even show up when you're initially symptomatic. You're going to show up when the disease has progressed and you have moved further up that health services pyramid to the more expensive care. And that drives up cost for everybody. So having insurance reduces the number of people that postpone seeking care due to cost, which means we can treat them earlier and more effectively. There are about 35% said they needed care but didn't get it. 37% of the uninsured didn't fill a prescription even though they knew they needed it because they could not afford it. And similar number had problems paying for medical bills. But what's interesting here is so did 16% of people who were insured, which showed that our insurance is very expensive and healthcare is still very expensive. And again, the number of people who had been contacted by collection agencies about medical bills. So this is just one example of the impact of late care. So this is looking at the probability of a diagnosis of late versus early stage cancer when you're comparing people who were uninsured versus people with private insurance, right? So these bars should all be right here at this line if there was an equal likelihood between uninsured and insured. But what you see is that people who are uninsured are twice as likely to be diagnosed with late stage colorectal cancer, 2.2 times as likely to be diagnosed with late stage lung cancer, 2.3 times as likely for melanoma, and almost 3 times as likely for breast cancer. And why does this matter? Well, particularly in the case of colorectal and breast cancer, we know that early care increases your probability of survival and increases your probability of recovery. For colorectal in particular, there are primary prevention strategies that are actually linked to screening. It's one of the few screenings that can be both primary and secondary, in that it can find precancerous lesions in your colon and remove them at the time of screening before they have a chance to become cancer. And so if you are uninsured and you are not going for your colonoscopy because you cannot afford it, because you're delaying care, etc., not only are you more likely to be diagnosed with late stage colorectal cancer, that means you're more likely to die. So people who are diagnosed in the early stage have about almost a 66 to 70% chance of 5-year survival rate. That drops to less than 30% with late stage diagnosis. So we're finding them later, it's more expensive to treat, and you're more likely to die. So this is why having insurance as part of the equation is important, but also having insurance that you can afford to use is important. So again, access to insurance is not always access to healthcare, but it's an important first step. So again, where do people get their coverage if you're under age 65? About 160 million people get them through employment. 80 million get it through Medicaid and children's services. About 30% have non-group coverage, so they buy individually. This is, again, these are for people who are under 65, so for Medicare, these would be individuals who are permanently disabled. And we still have a certain, I'm sorry, that's not 40%, about 30 million. And we still have about, between 25 and 30 million who are uninsured. If you look in 2006, you can see that health insurance coverage varied by race and ethnicity. So 77% of people who identified as white had private insurance. 9% were on Medicaid or public insurance. And these are, again, individuals under the age of 65, so 19 to 64. These are adults. And 14% were uninsured. Hispanic and American Indians were the most likely to be uninsured. Asian population and the white were the most likely to be insured, and there was the African American population was somewhere in between. This is 2006. As you can see, the rates for white individuals hasn't changed terribly. It's about the same. The amount on Medicaid or other public insurance has increased somewhat. Likewise for the Asian population. The Hispanic population has now better coverage. There are fewer uninsured, from 43% down to 32%. This seems largely due to Medicaid expansion. Likewise for the African American and the American Indian population. And when people say, well, just get a job, right? So if you want insurance, just get a job. Don't be lazy. A couple of things. First of all, and I'll talk about this again, but when we're looking at people on Medicaid or other Medicaid in particular, 75%, 3/4 of people who get Medicaid come from families where there is at least one worker. So the majority come from working families. So the idea that these are a bunch of lazy people who just don't want to get jobs is not true. These tend to be, yes, some people who are unemployed, but also very low-wage workers. And so when you're looking at people who are employed, who are poor workers, right? So very low-wage workers, 30% are covered by their own or their spouse's coverage. 15% had declined the offer, but more than half weren't even offered insurance through their employer. Compare that to high income workers, where 92% were covered by their job. Again, this is in 2005. This is pre-Affordable Care Act, and so those numbers have changed somewhat. But most poor workers may be working part-time or having multiple part-time jobs, none of which offer health insurance. And so this is looking at those rates again. So the percent of workers offered employer-sponsored insurance based on their earnings. If you're a high wage earner, you're pretty likely to get insurance through your employer, and that declines with wage. So the less you earn, the less likely you are to get offered employer-sponsored health insurance, and that those numbers have decreased a little bit through 2014. And so this was looking at the rate of non-elderly Americans with employer-sponsored insurance, looking at the rates, so between 66 to 60% in 2007. And again, non-elderly enrolled, not just offered, but enrolled in employer-sponsored. So 83% of high-wage earners have employer-sponsored health insurance, whereas only 12% of low-wage workers. And again, those are workers. And why might you not have health insurance? Well, when we look at the rate of health insurance premiums, again, how much does that plan cost? If you start at 1996, and this is the cumulative change, so from 1996 to 2011, for family plans, there has been a 203% increase in premiums. For a family, 162% increase for single individual plans. And when you look at where the federal poverty level is, so where they set that line, that's only increased 41%. So that has not kept up. Thus meaning there's going to be more people falling into that coverage gap. So prior to the Affordable Care Act, who was eligible for private health insurance? Well, there were two places for private health insurance. As I said, the employer-sponsored insurance, which was up to employers, less likely to be offered to employees of small versus large firm, seasonal or part-time workers, low-wage workers, newly hired workers. So most employers would say that you had a 90-day waiting period before your health insurance would kick in from the day that you started. Dependents, so if you had a family, it might cover you, but not your partner, spouse, or children. Sometimes it covers retirees. That's happening less and less, where you can retire with your insurance. But the important thing with employer-sponsored health insurance is it could not be based on health status. So if you were employed, they had to cover you. They couldn't not cover you because you were disabled or had an illness. Now, whether or not that impacted their hiring, again, that would be illegal, but I don't doubt that it happened. Individual insurance was purchased by individuals, whether within or outside of Marketplace, and age and health status could be used as a determining factor, and this is called medical underwriting. It was the amount of risk that an insurance company was willing to take based on whether or not you smoked, what your weight was, and what conditions you may have had, and your age. And so what did health insurance cover? Well, you had your covered benefits. This is your standard policy. It was rarely defined by law. And then they had mandated benefits, certain things that had to be covered. There were benefit limits. So there were annual limits on what you could spend. There were service and cost limits. And there were also lifetime limits, which were generally set at about $1 million, which doesn't seem like a lot of money. It's like, how can I possibly go through $1 million worth of care in my lifetime? Well, if you were a child with a childhood illness, or if you were born with a congenital disease or disability, childhood cancers, you can go through $1 million of care in the matter of a couple of years. Neonatal care is the most expensive care that there is. So you can run through $1 million fairly quickly if you are a child who is ill. And that's a lifetime benefit cap. Meaning once you run through it, you have the whole rest of your life where you could potentially not have health care. So those are the coverage benefits. There's cost sharing. So again, those deductibles, co-pays, co-insurance, which we covered. Um, some plans had out-of-pocket cost-sharing maximums. So once you reach a certain amount of your out-of-pocket max, they will kick in and cover 100%, even if you're doing the 80-20 split. There were provider networks. Again, so they're in-network. Those are doctors and medical groups that your insurance negotiated with to be considered in-network. And so if you go with those individuals, you'll have one copay. And if you go outside, you may either have a higher copay or no coverage whatsoever. And so you often have to have your care authorized. You get pre-authorization to go for different medical treatments. There were often condition exclusions. So if you had pre-existing conditions, which have been a lot in the news today or recently, they could deny you care. So I'll talk in the next slide about what some of those pre-existing conditions were, and we can talk a little bit more about what they are now or what they're being proposed to be. Employer-based insurance generally covers more with less cost sharing, but again, that depends on how much money you earn, because the more you earn, the better your care is. Small businesses, again, so they have more cost sharing because they don't have the same negotiating power, and therefore there's less coverage. And individual insurance is typically less inclusive. So what are some of those pre-existing conditions that were often denied by individual health market insurers? Well, things that were almost universally always denied: if you had a previous condition of cancer, HIV/AIDS, diabetes, MS, stroke, or pregnancy. So that doesn't mean ever being pregnant. What it means is if you are uninsured, you're pregnant, you go out, you want to buy insurance so that you can have coverage, you can't get it. They will not cover you. That pregnancy is a pre-existing condition. Pregnancy is very expensive. Delivery is even more expensive. And so trying to deal with that without insurance can be incredibly difficult. Often denied, you could be denied if you were overweight and if you had a cancer history. So again, this is if you currently have cancer. This is if you have a history of cancer, high blood pressure, asthma. People have been denied for having things like allergies, hay fever, acne. Again, things that can be expensive to treat. So before the ACA, not all large firms provided health insurance. And you think, why not? It's a nice benefit. They've got negotiating power. So 21% of uninsured workers worked for firms with more than 1,000 employees. And 35% of uninsured workers worked for people, were employed in small firms. Small firms claim they cannot bargain well with insurance and therefore cannot afford to pay for the health insurance because it would cut into their bottom line and they would be driven out of business. Large firms can't really make that claim, at least on any rational basis. But what they say are things like workers prefer cash to insurance benefits. So they'd rather have the cash in hand than pay for insurance. And that was largely true for individuals 19 to 26 that were coming off their parents' insurance and were trying to get established in the workforce and trying to get out and get your own place. So they said, you know what? I'm young and I'm healthy. I'd rather not have the insurance. Give me money. Pay me more. The problem was they still needed care. They would get sick and they would show up. And when they show up, because they didn't have health insurance, they would go to the emergency room, which is one of the, again, more expensive places to get your care. Another claim is that they had part-time workers, which is really a subcase of unwillingness to sacrifice the money wages argument. And minimum or near minimum wage workers, they would say, could not have their wages reduced sufficiently to compensate for health benefits. So there's this argument between minimum wage mandates and health insurance. And what some large employers say is, we can either pay you more or we can give you health benefits, but we're not going to give you both. Or it's not feasible to give you both. And then came the Patient Protection and Affordable Care Act, which often gets reduced to the Affordable Care Act or the ACA, or in some cases was branded Obamacare. You should know this because apparently this is something people did not realize. The Affordable Care Act, the Patient Protection and Affordable Care Act, the ACA, Obamacare, all the exact same thing. There is no different Obamacare from Affordable Care Act. So I will refer to it as the ACA or the Affordable Care Act, but it's actually the PPACA. So this was signed into law in March of 2010. And at that time, most Americans had health insurance, but millions did not and will find themselves after this covered. And as we said, study after study confirms the danger of being uninsured or underinsured. And without good insurance coverage, people just don't get the care that they need when they need it. And the ACA sought to remedy this. So the ACA sought to do several things, and the 10 sort of overarching frameworks were to improve affordability and accessibility, to increase the role of public programs, so to elevate prevention and public health work, to improve quality and efficiency in healthcare to reduce cost, again, improve the public health network with the goal of preventing chronic disease or reducing chronic disease, to grow the healthcare workforce through supporting undergraduate and graduate education in healthcare fields, to increase transparency and program integrity so people knew where the money was going and what it was doing, improving access to new and innovative medical therapies, to improve support for community living assistance services and support so that individuals requiring long-term care in their elderly years could stay in the community and not have to go into the more expensive assisted living homes. There were some revenue provisions, so how all of this was going to be covered, and to try to strengthen quality, affordable care. So in the very first year following the inaction of the ACA, insurance companies could no longer drop you when you get sick. All kids were covered regardless of whether they had a pre-existing condition. There were no more lifetime limits on benefits. Young adults were allowed to stay on their insurance until the age of 26, and all insurance companies had to provide for pre-preventive services. And that included blood pressure, diabetes, and cholesterol tests, many cancer screenings, in particular mammograms and colonoscopies, health counseling services, routine vaccinations for children, flu and pneumonia shots for the young and the elderly, and well baby and well child visits up to the age of 21. Again, these are all your preventive services, which we know are the most bang for your buck. Starting in 2014, U.S. citizens and legal residents were required to have some type of health coverage, and there was a phase-in of tax penalties for people without coverage. So the maximum penalty is $695 per year, which works out to, I believe it's about $57 per month. So if you don't have health insurance, that's what you pay. You pay for every month that you do not have insurance coverage. So it's not that you automatically pay $695, and that gets paid at the time that you file your taxes. It also started penalizing employers with more than 50 employees that don't offer coverage. And it created these state-based health exchanges and small business options program exchanges through which individuals and small businesses could purchase qualified coverage. It also created an essential health benefits package that said this is what must be included in policies that are sold through the exchanges. So it provided, again, a minimum of care, and there were different levels that you could purchase. In order to help people purchase through those exchanges, it provided subsidies and it limited out-of-pocket expenses. And for eligible individuals with families' income between 133 and 400% of the poverty limit, you could get those subsidies. And importantly, in 2014, it prohibited the use of pre-existing conditions as exclusions for adults. So in 2012, it started with children. 2014, that expanded to adults. Since 2015, it was going to permit states to form multi-state health care choice agreements to allow insurers to sell policies in any participating state, and it would tax health insurance policies with high levels of coverage. That's generally where we are now. As you may have heard, um, a new bill has made its way through the House of Representatives. It has not been picked up at the Senate yet. They have not presented their plan. So the the American Health Care Act, or the AHCA, has been presented as an option to the ACA to repeal ACA and instead use the AHCA, American Health Care Act. And so this would repeal the individual and employer mandates saying you have to have insurance. And according to the Congressional Budget Office, this would result in premiums that would increase generally for everyone between 15 and 20%. And it would potentially, private coverage would decline by about 8 million, with 6 million who would lose their insurance through the individual market and 2 million through the employer market. And starting in 2019, it would allow older enrollees to be charged as much as 5 times more than younger enrollees, which is currently around 3 times more in their premiums. So premiums would go up, the rate of uninsured would actually go up. And so when you're looking at changing coverage, the Center on Budget and Policy Priorities has shown these are the rates, the current rates of insurance coverage. Uninsured, which has gone down. And if the AHCA goes in, it's projected to go pretty much right back up to where it was pre-ACA and possibly slightly higher. So the House bill would also cap federal funding for the more than 74 million low-income children, adults, seniors, and people with disabilities who are currently covered with Medicaid. And it would also phase out the enhanced federal funding for the 11 million adults who are newly eligible for Medicaid under the ACA Medicaid expansion. And so if you're looking at the dark blue, which is current law, and the light blue, which is the proposed AHCA, if you are looking for higher income individuals, people who are 200% or more above the federal poverty line, you're looking at an increase in rates of uninsured amongst non-elderly. Those rates would skyrocket for people who are near or below the federal poverty limit. And so what would happen? So as it's currently written, the AHCA would replace a number of the ACA policies for the individual market, including reducing the premium tax credits by 50%. It would repeal the Medicaid expansion that started. That would repeal it starting in 2020, along with several other ACA Medicaid policies. It would create a per capita cap on federal Medicaid spending starting in 2020, and would repeal or delay most of the ACA taxes. These changes would reduce benefits by about $1.2 trillion, primarily for Medicaid enrollees, who would lose about $880 billion worth of care, and cut benefits for middle-class Americans by about $318 billion. At the same time, this plan would create $861 billion in tax cuts, which would go to primarily high-income individuals, about $355 billion, and health insurance and drug companies and other corporations, about $506 billion. It has been estimated that the after-tax premium increase for a 64-year-old earning $26,500 would be $12,900. So almost half of their income would now go to medical care premiums, which would leave them about $13,000 a year to live on for mortgage, property taxes, food, clothing, etc. Try doing that in New Jersey. So while the tax cut for a 64-year-old earning $1 million a year, so that very wealthy, would be, you guessed it, $12,900. So, again, this would disproportionately hurt middle and low wage or low income individuals. So the combined tax savings gained from cutting the insurance premium tax credits for 800,000 people would provide tax cuts for the top 400 earning households. So, where would the money come from? The low and middle class. And where would it go? Pretty much to 400 families. In addition to cutting the Medicaid expansion, it would also change how we deal with those who are considered high risk, those pre-existing conditions. So the way insurance works is that you pay in whether or not you need the coverage right now. Again, if you think about car insurance, you hope you never need it, but you pay into your plan with the assumption that you will be covered when you do need it. So the premiums that you pay each year aren't earmarked specifically for you. Instead, that money is in the pool and gets used to pay out claims for other people who have the same insurance. The same is true for health insurance. Private health insurance pools risk so that premiums paid by enrollees who have low claims costs help pay for the claims for the small share of enrollees with higher costs. And so, how does that work? Well, the healthiest 50% of the population accounts for less than 3% of your total healthcare expenditures, while the sickest 10% account for about 2/3. And so who is included in high cost and low cost groups changes from year to year. So most people are healthy most of the time, but illness and injury can onset unexpectedly for millions of people. And some high cost conditions persist and require treatment for extended period of times, even over a lifetime. Other high cost conditions can improve or resolve, allowing patients to return to low annual healthcare spending. And so, in any given year, among the 50% least expensive, 73 will remain in that same group for a second year. And amongst the people who are among the most expensive 10% of the population in 1 year, only 45% will stay in that group for a second year. So your risk ebbs and flows each year. I will share, my family had one particular year. I gave birth, I had a C-section. 4 weeks later, she had the flu and was hospitalized. My son has tonsils and adenoids taken out. My husband had to have back surgery in 1 year. That was a very odd year for us. We don't typically do that. I rarely need to go to the doctor. So it sort of ebbs and flows. Prior to the implementation of the ACA, insurers selling individual insurance commonly practiced what I mentioned before, medical underwriting, which excluded people with pre-existing conditions or charging them higher premiums. And medical underwriting effectively excludes a large proportion of total healthcare spending from the insurance pool. So this can permit for less expensive policies for healthier individuals, but requires some other way, such as high-risk pools, to help finance costs attributable to the sickest individuals, if they are to be covered. And enrollee premiums can finance a portion of the cost of such programs, but by definition, significant additional funding is also required because the cost to cover each of those people is substantial. High-risk pools originated in 1976, and they were created on a state-by-state basis. These were individually used to cover individuals who otherwise would be shut out of the health insurance market, namely those with pre-existing conditions. The types of high-risk pools have changed over time. By 2011, there were 35 state high-risk pools, which covered about 226,600 individuals, or about 2% of the non-group health insurance market, according to the Census Bureau. Premiums in these high-risk pools were significantly higher than for traditional non-group market rates, were generally capped at about 150 to 200% of market rates. And a few states did offer subsidies for low-income individuals or families, but not all. And remember, this is in 35 states, not all 50. There were pre-existing condition exclusion periods. So most states had exclusion periods for individuals with pre-existing conditions that ranged from 6 to 12 months. This meant that if you were enrolled in a plan in January and had a heart disease, the insurance would not cover treatment for your heart disease until, at a minimum, July of that year, and in some cases, not until the following January. The problem with this is that those pre-existing conditions were often the reason you needed to be in the high-risk pool in the first place. 33 of the 35 states impose lifetime limits of coverage of between $1 and $2 million. And as I said, this sounds like a lot until you consider the cost of things like neonatal care and childhood cancers. And remember, these are lifetime caps. So if you're sick as a child, you can be denied coverage for the rest of your life. In 29 states, the deductibles for coverage were $1,000 or higher, and in 10 others, it was $5,000 or more. So very, very high deductibles. And even with these high premiums and deductibles, the pools operated generally on a net loss, meaning their expenses were higher than their revenue, and the costs were generally offset by tax credits by the state. Thus, they were actually a mix of both individual and state-funded programs, and there were federal grants that were used that were also available to offset costs for these pools. When the ACA was enacted in 2010, it created a temporary high-risk pool program to cover individuals with pre-existing conditions that were uninsured for the previous 6 months, and that lasted until 2014 and appropriated about $5 billion to fund expected net losses during that time. That proved to be a bit insufficient. In 2014, new rules prohibited private non-group policies from discriminating against individuals based on pre-existing conditions. The AHCA is proposing to bring back these high-risk pools with federal support of only $8 billion, which is not expected to sufficiently cover those individuals who will be newly insured due to those pre-existing conditions. And therefore, there's significant concern about how those individuals with pre-existing conditions will get care, or if they will even be able to get care. And so there's a lot happening. Now, the American Health Care Act, as it stands, has only made its way through the House of Representatives. Typically what will happen is the Senate will take it up, will create their own bill, which they will then pass. It will then need to be, or if it does pass, would need to be reconciled. So the two bills would have to be reconciled to see what they agree on. That would then be voted on. It would then go to the president to be signed off on. So this is not a done deal. There's a lot of work to be done. But if this is something that you are concerned about, and most people in public health are concerned about what the AHCA will do in terms of increasing the rate of uninsured, making people, or that would create large people who are uninsured not accessing preventive or primary care, which we know is going to be helpful in reducing costs in the long run. This is something you should be aware of, it's something you should care about, and it's something you should at least be knowledgeable about. Whether or not you support the ACA, the AHCA, or something in between, it is very, very important that you be informed about what that means. And that also means going to trusted sources. So go to the CBO, go to the government pages, go to Kaiser Family Foundation, Pew, etc., research groups that do this that are nonpartisan. This is your overview of health insurance in the United States. In the next video, we will go into more depth in understanding the history and current status of Medicaid and Medicare.